excellence. Third, we address the social determinants at the root of poor health. Fourth, we integrate digital and product technologies for high-tech, high-touch models of care. Fifth, we innovate operational models that enable efficiency at scale. Learn more at www.medtronic.com/Medtronic Labs.
The world is on the brink of a digital revolution. Almost everyone in Africa has access to a mobile phone. To capitalize on this opportunity, we've initiated a digital platform that connects all players in the healthcare market, bringing transparency, efficiency, and direct access to and for end users. This technology generates a wealth of data that can help improve quality of care in unprecedented ways. And donors, governments, insurance companies, and even individuals can reach vulnerable groups or family members directly or contribute to digital funding pools, knowing for sure that their money will only be spent on health.
Here, you see the agenda for today's event, themed financing models. I would like to reiterate, this is a 90-minute session. And now, it is my pleasure to introduce the moderator for today's webinar, Professor Kamarogo, who will also give the keynote address. Professor Kamarogo was the lead health sector specialist with the World Bank and head of the World Bank Group's Health in Africa initiative. Professor Kama is a recipient of multiple awards and honors in the region and abroad. He continues to pursue in academia through numerous adjunct professional appointments, lectures, and supervision of postgraduate students in universities in Africa, Europe, and North America. He's the first recipient of Kenya Lifetime Service Achievement Award for Excellence in Quality Healthcare 2019. He's currently the founder of the Africa Institute for Health Transformation. Join me in welcoming Professor Kamarogo. Welcome, Prof.
Thank you very much, Jacob. Thank you very much, the organizers. And thank you very much for the participants. It's an honor and a privilege to be asked to, number one, give a few remarks before the real substantive presentations by these able panelists. And secondly, to moderate. Doing the two things is challenging, but then health sector is challenging, and I love the health sector, so I like challenges. I've been asked to open the conversation on health financing in Africa and models. First is health financing, what it is, and two is models. But I want to step back because I will take less than the 10 minutes that's been allocated to me and make most of my presentations in terms of questions that should challenge us, but most important, stimulate us to do better, because indeed we must. Finance is absolutely critical for this sector. But from my many years of working globally, I can state here without fear of contradiction that there are very, very few countries in which you can land at the airport today, go to the Ministry of Health and ask for the health financing strategy, current one, and you will get one. In fact, I would say none. But then there's a lot of discussions at the country level, year in and year out, about national health strategies, but they never get completed. So what I have met in all the capital cities of Africa have been pieces of unfinished work or work that is continuing on health financing. Why has it been so difficult for our countries to have clear strategies and finish those strategies and make them current, but most important, implement those strategies? The first one is historical, that health in our part of the world, modern healthcare in Africa, are patterned along what I call the colonial past. So if you go to English-speaking countries, you will find a pattern that is so similar whether you are in Zambia or in Kenya or in Uganda or even India. You go to Francophone countries, then you find some similarities on that side that are quite different from the way the Anglophone side has been planning. So is it on the Lusophone side. I don't want to mention the Arabic side of Africa because you do have those problems. On top of that then come the modern era of international external development partners who have big interests and sometimes very heavy interests. So you'll find that there has been support from WHO, from UNFPA, from UNICEF. There'll be input from USAID, from DFID, and from everybody who calls themselves an agency. And they'll come in with ideas that the country is supposed to put together into one strategy. So what I have seen is situations where an unfinished strategy, after 2 years, probably the Director General has moved or the minister has moved, another partner has come in and is now the lead in helping that country put together its strategy. And on and on and on. Sometimes it is because that agency in its mandate had strategy in that mandate, although the country already had something, and they throw everything out and start afresh. So we have a problem in terms of defining what our current strategy is for most of our countries. The second thing has been that because of the input into this sector, or shall I put it, because of the complex sources of financing, the people who put in money want to also be part of the strategic planning. Totally against the Paris Agreement, totally against the Accra Accord. And you will find their footprints, whether it is World Bank or whatever, in all those things, because they've come with an expert who's helping do this and that. Some of those also are tied to what we may call the global initiatives, the disease programs, be it HIV, AIDS, and so on, Global Fund and so on. They come in and they want to see where they fit in with that strategy. All these things are happening in a country where it is a developing country with resources that are limited in the ministry, and they want to do their best to move forward. So the ministry will be trying its best. But as it does so, it's also looking on over the shoulder, because whatever they write down has to be looked at by the Ministry of Finance. And the Ministry of Finance sees the health sector as a problem, as an expenditure area, an accountable area, and they'll give you lots of problems before they give you substantial contribution to this strategy. God forbid, even when they say yes, that does not guarantee you the money that they will give you over the next 5 years. Because the monies that come from the Treasury in allocation of the budget often has nothing to do with what was in the strategy. You panelists and others will correct me if you've seen otherwise, but I can tell you these things are usually disconnected. So we have that problem of a strategyless or an incomplete strategy situation in the continent. That builds then on to the colonial pattern of healthcare that we inherited. And the pattern that we've inherited in our countries has been essentially that the colonial system gave care to the people they could reach. They were not mandated or committed to giving care to everybody because they were in transition. When our governments took over, we promised our people healthcare. So our governments take over a system that is not supposed to give healthcare to everybody, but they come in with a promise that they want to eradicate disease as one of the manifestos. So they now come in using a different vehicle to deliver something that is more complete than was intended. And this is a quagmire that they find themselves in. But as soon as they take over, they find that actually the resources that they can allocate to health sector is not adequate. And later on in the era of aid, you start looking at our health financing mechanisms, and you find the following. Number one, that from the national treasury, probably at most, the government will put in 30% of the expected expenditure. At most, sometimes it is less than that. Then the donors will put in probably another 30%. In some instances, it could go sometimes up to 70%. And I can give you examples of how those have happened over time. The biggest expenditure in the health sector in Africa is out-of-pocket expenditure. But the out-of-pocket is so disorganized that these people who get money out of their pocket, who are supposed to be mostly the poor people, are not represented in any strategy-making process. So although it is a substantial amount of money that comes in, it comes in a disorganized manner and is unrepresented in the strategy. So you end up then with a strategy that is not only incomplete, but is done by most within the absence of the people who put in most of their money. And number two, it starts reflecting then the people who can pull the strings at any given time and move on. Add that then to the extra budgetary expenditures that come in through other vertical programs that the Ministry of Finance probably has no complete control on. And you can see the quagmire that we are in. But within this quagmire, several patterns are coming out. Really, if you talk of models, what Africa should be asking is that of the three possible models, which one do you choose and how do you work with them? Which are the three models? The three models are to do with the manner in which we get the money and the manner in which we spend it. Most of our money, as I've said, is coming from out of pocket, but we don't know how to collect that money. There is, of course, the treasury that gives money, oftentimes more in terms of the figure declared in the budget, but in terms of its release, both in timing and in quantity, is unpredictable for the year. And then you have the donors who also fluctuate here and there. So which are the three? One is that, are we looking at what we call the supply side financing, which traditionally is what we inherited at independence? Or are we looking at a different side of financing where the monies are coming from within and then are spent, which is the opposite of the supply side, which is where things like insurance and so on would come in, demand side financing? Are we clear about those and how they work in our countries? And the third model would be a mixture of the two, which some of our countries are moving into, where they're doing supply, it is also demand, but it is mixed. These three models are the ones that we are all struggling with. And we're struggling with them to the point that they're also fighting each other. I'll explain how that is to be. In most countries, the supply side has been dominant, and it has been dominated by a promise by a government that we have allocated a budget that will provide quality care, basic, to everybody. So it's telling its people, go to the hospitals, we are taking care of you. Don't worry about having a card or anything, just walk in there and walk out, and you will get it because health services are free. Or if they are not free, you will pay a registration fee, and then you will get the rest of it free, irrespective of the level. We have done that for 60 years in most of our countries, and it has failed miserably. Then comes the attempt with the second model, which is demand side, which is that people, probably if we use social health insurance as a vehicle, that they are registered, they pay something or it is paid for them, and they have a card that guarantees them care. And when that care is given, then the provider is going to be paid. The first one, the provider has been given the money irrespective of whether they give the care or not. The second one is the provider only gets money after they have given service. Now, in moving towards this, the last 10 years, I still remember, the AU 10 years ago declared the decade the last decade as a decade of social health insurance in Africa. Not much happened in it, but we saw during that time the emergence of models of social health insurance like we've seen in Ghana, like we've seen in Rwanda, like we have seen in Kenya, as we are attempting in Tanzania and so on. They are incomplete models, their business going on, but they have faced major problems that we can discuss later during the question time. What we have seen though, is that for a lot of countries, even when they start applying this second model, they still want to stick on to the first model. So you have a situation where the Ministry of Health does not want to let go what it is getting from the Treasury. But at the same time, they want to get this social health insurance money that is paid for directly or indirectly from the people, from the people's pocket. This mixture has meant then that there has been double investment or double billing to both sides, to the point that we do not know who is doing what at the end of it. We can discuss how those middle models work and where those monies come from and so on. So we end up then in a continent where we have a mixture, where none of them is working well and none of them is pursued towards delivery of what we want, which is quality healthcare. Now comes the next big question. Where does the money come from? I've mentioned previously that all our monies in healthcare come first and foremost from my pocket and my poor relative's pocket here in the village. That is supposed to go into the care, despite the promise that it is there. Then we have this thing that is called a budget that comes every year that is supposed to not only allocate money to the sector, and then the sector is supposed to allocate money to the different activities, including regional and district allocation. On what basis is that done? It is not clear. On what basis is that monitored in terms of accountability? It is not clear. So that money there right now, we know most of it does not go into very useful thing, except for countries where we can account for it in terms of paying salaries. So we have a situation where the government budget, probably 70%, in some instances, 90% of it goes into paying the workers' salaries, emoluments, with nothing else left for buying medicine, nothing definitely left for infrastructure and so on. Then, of course, there is the donor money that comes in. Most of it is tied to specific programs, and therefore you are unable to use it fungibly. Now, the biggest battle then is who actually calls the tune. The tune, is it called by the Minister of Finance? Is it the Minister for Health? Is it a donor? Is it the District Medical Officer of Health? Or is it the people from whose pocket this money comes? We have a problem in that in the whole continent. Let me finalize by talking about accountability. Whatever that model is, we have one of the weakest areas in this sector is accountability, for several reasons. One is that our strategies do not have accountability as part of that strategy. Extremely weak. Read all of them. And believe me, I've read virtually in every African country. In the area of accountability, for the money that you get, what are you going to get for it? And then is somebody checking at the end of the year whether you reached there? And is the following year's budget based on what was spent? Absolutely not. Accountability is weak. Secondly, of all the sectors, government sectors, health sector stands usually as number 1, 2, or 3 in terms of the volume of public procurement. And public procurement is an ocean of graft and losses that none of you I know will want to talk about in detail. Where there is much public procurement, you have lots of losses and lots of leakages. And whatever strategy we have therefore, the question is, what do you procure and who procures it? This is both for demand side as well as supply side. because we've seen the social health insurance issues too, and companies also coming in with a problem of how to pay the provider, how much to pay the provider, because we actually do not have a clear idea of the cost of care, the unit cost of care. My final point, the private sector, a provider of at least half of healthcare in Africa, but one whose resources and participation is usually not recorded in our national health strategy. Yes. These private providers in every subsector in health, from governance to the result framework, the measuring of what's coming out. But nobody actually knows how much money they put into the economy, into the health sector. And our countries usually are not interested in it. And if you start looking at our health strategies, where they have been written, you'll find that there's very, very little that is showing what is coming from the private sector, both as investors or as people who are paying for the care. This makes our picture incomplete. So if I was a Picasso, and I believe that you can be a Picasso in this sector, and I was doing a complete picture of the health sector financial strategy in Africa, I will tell you that it is a difficult one to draw, because right now it is thoughts here and there, stories here and there, and not a complete story. That is what I would like us to take up today when we start talking about models and models that work for the future. Now comes the area of the pandemic, COVID-19. COVID-19 and any other epidemic that we've had, be it Ebola and so on, just comes in to mess us up in an area that's already messed up. How much money comes in for these epidemics and pandemics? Lots of money comes in suddenly. Accountability is even less during that time, and usually it completely wipes whatever strategic plans we had in place. And that's what we are seeing in Africa at the moment, that if you went to the African ministries of health and ask them, to what extent are you quitting what you have right now, you'll find that none of it is happening. Allow me to stop there because I'm getting ready for the heat that should come after my presentation and the participation of the luminary panelists who are here with us. Thank you very, very much for the opportunity to do this. Jacob, I'm informed that after my comments, there should be a pause for a video. Thank you very much.
هر روز نگران این هستیم که مبتلا به این شده باشیم.
خايفة من البيبي اللي ببطني، بس أنا الإجراءات اللي أخذتها أكيد حتكون الوضع تمام. كلهم عالجوا الخوف مع القلبهم والرعب إنه خايفين من هالموضوع انتشار كورونا شو أثره على الجنين. Do nosso pulmão ficar meio beba, podemos reflexionar, ideia de cidadania, anti, mentor, cidadão beba.
درصد که میترسم، ولی خب اگر ما هم بحران شونه خالی کنیم. احساس میکنم مثل که خط اول یعنی خط مقدم رو خالی می‌خوای بکنیم و این الان توی این شرایط موقعیتی نیست که من این کار رو بخوام انجام بدم.
Thank you very much. That spotlight was UNFPA leading me to introduce Justine Coulson, the Deputy Regional Director for East and Southern Africa of UNFPA, to be our first panelist. Over to Justine.
Thank you, Professor Rogo, and thank you for your thoughtful opening remarks. Actually, much of it I would agree with, so I'm not sure how much debate we're going to have. You know, I think as you saw actually from that video, what strikes me at the moment is when we made that video, that was before COVID had actually hit Africa. It's why you don't see much footage from Africa at that time. And I think if we were to make that video again now, sadly, the images would be very different, as we know that the pandemic has really affected so many of our countries across the continent. So the chair asked me to be very brief in my opening remarks. So I'm just going to make 3 comments and then hopefully we can open it more to questions and debate. I think echoing what Professor Rogo opened with, as we think about moving out of COVID and we think about how we finance healthcare, we cannot underestimate how severely underfinanced the Africa health system was before COVID. So recognizing that, you know, if we take the $86 as the minimum that we need to have invested in a healthcare system per capita to ensure that we can have essential services covered, only 20% of African countries were able to make that level of investment before COVID. You know, and I think as Prof also mentioned, you know, we see a huge reliance on out-of-pocket expenses. We have to recognize that much of that income is actually coming from remittances from overseas, and at the same time, a dependence on external finances and overseas development aid. We have to recognize that post-COVID, remittances will decrease. Those households that are already covering at least 20% of national health financing will actually have fewer resources due to economic downturn, very likely. And also that for countries that are big donors into health systems, where the levels of aid are tied to the performance of the national economy, we will also potentially see a reduction in development aid available to countries that require it. So we're really moving into an extremely challenging time in terms of how do we finance even the minimum package of services that we want to make available to all Africans, regardless of their level of income. I think my second point is around the fact that at the moment we are seeing a triple burden on the health system in terms of COVID. So the first one is obviously that direct health impact. So how can countries fully fund all of the prevention and treatment that they need for COVID-19, which I think has been extremely well covered in the press. But the second one is around the indirect impact that we're seeing on health service provision because of COVID-19. So the severe disruption to essential health services. So for example, as you saw from the video for UNFPA, we work specifically in the field of sexual and reproductive health services and also gender-based violence prevention and response. And we're seeing that many, many countries are struggling to maintain those services during the time of COVID. And at the same time, even those governments that have managed to very quickly and effectively set up alternative modes of delivery, whether that's mobile services or a physical separation of COVID and non-COVID services, that in itself puts an extra resource burden on the health system. And I think we have to recognize that without ensuring that we keep that focus on maintaining funding in that essential service area, we could see a devastating impact for women and girls, particularly in the field of sexual and reproductive health. The third area of burden is actually around the socioeconomic impact. Because what we see is as socioeconomic markers show a deterioration, that actually has a knock-on effect in terms of determinants of health and negative health outcomes. And this is what we're also starting to see now. And populations, as socioeconomic downturn occurs, will actually be more vulnerable to negative health outcomes. To give you a very precise idea of what this might mean, so when we look at the disruption in maternal health services, for example, across East and Southern Africa, current estimations are that there could be up to an 8% increase in maternal deaths, i.e. an 8% increase in the number of women who are dying due to childbirth because of the disruption of services during COVID. And that actually is it would mean that we would lose 3 years worth of progress that we've made in the region in terms of improving maternal health care across East and Southern Africa. I think my third point is where we go next. You know, and I think as Prof laid out, there are these 3 particular models. I think we do have to recognize that there is no perfect health financing model. There is no perfect health system. There are just better health systems than other health systems. And so, you know, I think there are African-grown examples that we can learn from and draw on and look at the extent to which they are applicable to other environments or other countries within Africa. So for example, we can take the community health insurance model in Ethiopia that really did enable informal sector workers to get into a health insurance system and actually access better healthcare. We can look at the partnership that's emerging between Africa CDC and the Afro Champions, so the Pan-African Business Organization, to really mobilize money specifically for investment in COVID-19 prevention and treatment across Africa. Or we could look at an example like Safe Hands Kenya, where it's startups that are coming together to see how they can work in a very entrepreneurial way to strengthen responses to the needs of the communities during the time of COVID. I think what's important is we can't think of financing separately from financial protection, i.e. those who are on low incomes or live in poverty should be spared the risk of going further into poverty because of health or a health shock. And I think also we can't separate a discussion around financing from a discussion around functionality and what does adequate functionality of a health system look like. So sometimes when we start talking about health systems, we imagine a fully functioning health system with all levels of the most advanced care. But if we could even just get primary health care right, before COVID, only half of African health facilities were functioning. If we could get all of our primary healthcare facilities across Africa functioning with those basic essential services, that would actually save thousands and thousands of lives every year. So I'm looking forward to a discussion about how we can achieve that and finance that, and how UNFPA can partner with others to achieve universal health coverage. Thank you.
Thank you very much, Justine. To the point, and we'll be discussing. Partner Spotlight comes next from AXA.
Because tomorrow is full of promise, and everyone deserves health and peace of mind. We are here. We partner with you through social protection schemes to create innovative solutions and facilitate access to care. Promoting prosperity by protecting the most vulnerable, by sharing our technical expertise and financial strength. We are here to empower people to live a better life.
Thank you very much. Allow me to introduce Dr. Philippe Francois, the Global Head of Life and Health, International Reinsurance Business Development, AXA. Philippe, you've heard us mentioning a lot of the public sector. I'm sure that you'll give us a sense too of the private sector and innovation. Over to you, Philippe.
Good afternoon. So pleasure to be with you. I don't know if my slides will come on the screen, but I can speak perhaps without the slides. Globally, we can go in the next slide. Globally, we know that effectively COVID, as you said, Mr. Kama, has created a perturbation on the health strategy, but we will say that it has also shown that health systems and health is one of the most important things, and that the universal health plans that have all the African countries are important. Obviously, it has also created additional financial challenges, because obviously if your national income dropped by 10%, it's more or less what should be in ideal the level of expenses for the health, so it creates a problem. But the good news, I think, is that these long-term plans should not be interrupted. As you say, Mr. Kama, strategy is important, and that emerging countries can benefit from innovative low-cost model and not necessarily replicate, I love your word, colonial model. For example, the Bismarckian model that sometimes I see that is applied in Africa should not apply, because more or less the people are mostly in the informal sectors. And the model that was applied in France in the year 70 is not necessarily the one that you have to apply in Africa. And also the chance is that in Africa, you have no or less legacy, and you can directly apply modern technologies. And when we see the success of Africa and the leadership of Africa, for example, in mobile technology, it can be applied, I'm sure, for health, for example, for, you were speaking, Justine, about primary care, but for example, telemedicine, I think, can go quicker in Africa than probably in countries like France when you have legacy. So, and if you see, for example, other countries, a country like Chile, that is a middle income countries, are more or less the same life expectation as United States, and the level of budget they have for healthcare is more or less 6 times less than United States. Countries like India have implemented reasonable systems of secondary and tertiary care for 20 euros per family. And so you can leverage, because they leverage technologies, biotech, they leverage IT. So basically, I'm sure that Africa can leverage technology to build low-cost model, reminding that health is not an expense, it's an investment. So the experience we have with different countries, as you said, Mr. Kama, it's very important to have a strategy, and sometimes effectively, because of the complexity of histories, because of the complexity of stakeholders, when we discuss in some countries, it seems that strategy should be clearer. And effectively, strategy is about prioritization. For us, we think that it's important to prioritize the most in a limited budget, the most vulnerable, not providing care necessary if you have a limited budget to everybody, but not, for example, to the people that already pay, but to the most vulnerable. It's also important politically. It means the most vulnerable, you cannot expect them to pay. Sometimes I see some models where people want everybody to pay, but the most vulnerable cannot pay. It's also important, I think, to prioritize your system in terms of disease. Effectively, as you say, Justine, you cannot imagine in Africa to implement for a limited budget a system that does everything, cares everything for everybody. And for example, prioritizing when you have already a decent primary care system, secondary and tertiary care, or including some disease like cancer, when the financial burden, the out-of-pocket is the most important, is a clever way to limit the budget. Start small with limited priority. And last but not least, leverage technologies. Leverage, for example, mobile phone. We are speaking about mobile phone. Mobile phone can help to have automatic access to most of the population that is already involved. It can be including a way to finance health. Effectively, in some countries, tech infrastructure are huge margins, so it could be a way to collect some tax to finance healthcare. We see this in some countries, and leverage also private infrastructure that exists and international experiences that can allow also to decrease the cost, especially in terms of drug. Sometimes we see that in some African countries, for example, the cost of cancer in some public hospital is 10 times more than the one we see in Asia. So it could be achievable for Africa to decrease this cost with economies of scale. So next slide. Effectively, how can we help as insurers? Effectively, we've adopted, and we call it indeed social insurance. An health system is a social insurance. And sometimes it's very difficult. You were speaking about supply approach. Effectively, we see that everywhere in the world, it's difficult for the government to fix its budget. And insurance, it's about fixing the budget. It's about fixing the budget that needs the government and ensuring that if there is a lot, it's for the insurer. So insurers can help to fit the budget. Insurers can help to manage the claims to avoid fraud. You have always in all health system, it's a pity, but elements of fraud, and effectively to have a third party that manages the claims helps to decrease the cost. An insurer can also help to bring systems, to build international experience, to bring providers. That's it. Perhaps the next slide in summary, insurance system, you are speaking about is very simple. The government it's paying a premium. It's social insurance to an insurer that manages the schemes and ensure there is no loss and there is adequate quality of service, managing especially the medical providers. So, thank you.
Thank you very much, Philippe. You have brought in lots of things that are relevant to some of the questions that are already being raised. We'll go directly to Ms. Oluranti Doherty, Head of Export Development of Africa Export-Import Bank. Oluranti, you are the one panelist who's coming from a bank. And amongst the things that I would like you to address is a common question that's coming up on level of monies that are available for lending to African health entities, not just governments, but to private sector. With that, we have in mind that the backbone of private health sector in Africa are the SMEs, the small providers, who are usually very, very far away from the bank with the kind of things that we want, the bank wants from us. Also, help us understand how you can run a business and pay back when you're treating poor people who can't pay much, but the interest rates in our banks in Africa are 30, 20, 40%. Over to you, Oluranti.
Thank you, Prof, for laying the background and for the detailed presentation. I also want to thank my other co-panelists for their analysis. Prof, I see myself as coming to answer one of your key questions from earlier on when you were presenting as to where does the money come from and is available out there to support private health sector businesses in Africa. I'll be presenting the bank's innovative financing solutions that we developed to support the healthcare infrastructure in Africa and to support our member countries alleviate the impact of the ongoing COVID-19 pandemic. So just to start off, I would want to just give a quick overview of the bank. Afreximbank, as you well know, is a multilateral trade finance institution established in October 1993 under the auspices of the African Development Bank. We are headquartered in Cairo, Egypt, and we have 4 regional offices across the continent in Zimbabwe, Nigeria, Cote d'Ivoire, and Uganda, with 51 participating member countries. The bank, created an health and medical tourism program. This is a bespoke program to try and attract investment into Africa's healthcare space to support the development and upgrade of existing healthcare infrastructures or new infrastructures across the continent, and to try and strengthen the healthcare systems across countries of the continent. This program has 2 main components. It has a range of financing facilities, like project finance facilities for the development of greenfield or brownfield health and medical facilities. It has franchise finance facilities that support the acquisition of medical franchises across the continent. And then it has medical and equipment financing facilities to support the acquisition of equipment in healthcare facilities. And then the second part of the program is the African Medical Center of Excellence Initiative. This sort of speaks to one of the questions that was posed by, or one of the comments that was posed by Philip on the need to create economies of scale. The bank created the initiative to develop a network of regional medical centers of excellence across the continent to be able to provide specialist healthcare services to Africans. And the bank is already moving on with the development of the first medical center of excellence in Abuja, Nigeria, with construction set to commence in first quarter 2021. The center will focus on providing full spectrum of services that cover oncology, hematology, sickle cell anemia, cardiology, and general services. But apart from this, the bank has a whole other range of instruments that we have put in place to support healthcare sector. One of them is the Afreximbank Project Preparation Facility. One of the key things we've noted when looking for bankable healthcare projects, especially from the private sector on the continent, is that most of these projects come in hardly prepared or bankable states. And so in reaction to that, the bank decided to put in place a project preparation facility. And this will be provided to private sector investors, public-private partnership organizations, or even government entities who intend to develop healthcare projects on the continent. So it will help them in developing the business plan, feasibility studies, and technical studies. It will fund this. Then we have the bank's trade finance and guarantee facilities, which is what the bank has been generally known for. And under this, the bank can provide forfeiting facilities to support the importation of capital goods and equipment required for the healthcare sector. The bank also has put in place an advisory and trade information services desk. These teams are ready to support private sector investors in mobilizing equity required to develop their projects. So this is one of the few services that the bank has put in place. Then finally, the bank has the Fund for Export Development in Africa, which is a subsidiary. And that institution is able to invest equity in healthcare businesses across the continent. This fund is unique because it's developmental in nature, and it will welcome healthcare projects that are growing and want to transform to the next level. It will take a look at this, and it's willing to invest either equity or quasi-equity instruments in these projects. With the bank's health and medical tourism program, we've supported quite a number of projects across the continent. We've supported, for instance, a 250-bed diagnostics hospital in Uganda, diagnostics and outpatient facility in Liberia, a 50-bed specialist rehabilitation center in Nigeria, 170-bed Center of Excellence project in Abuja, Nigeria. These are things the bank has put in place pre-COVID. But when the COVID pandemic struck, Afreximbank was one of the first DFIs on the continent to come up with financial and non-financial interventions to support our member countries in alleviating the impact of this pandemic. And one of the interventions provided by the bank is the 3 billion pandemic trade impact mitigation facility called PATIMFA. This facility was put in place to support our member countries in dealing with the economic and health impacts of COVID-19 pandemic. Through this facility, we were able to provide loans to countries, financial institutions to enable them meet trade debt payments that were falling due. We were also able to use this facility to support the importation of required COVID-19 materials, food, agricultural inputs. Currently, the bank has put in place a 200 million facility under an Afreximbank UNECA initiative. This facility, I would like to really place an emphasis on it today. It's to provide debt financing to support the capacity of African suppliers and manufacturers to produce and supply priority healthcare needs and pharmaceutical and medical supplies, such as face masks, personal protective equipment, test kits, etc., on the continent. So the bank is offering this facility to private sector stakeholders across the continent, governments and FIs, financial institutions. And this facility is at very special pricing. And I would implore people who are involved in producing these supplies to take note of this and know that the bank is providing this. Apart from just facilities or debt financing, the bank also put in place a 3 million grant to support our partners like the African Union, the Africa CDC. We also supported the Africa Organization for Standardization, just to ensure that they could also are able to live up to expectations and meet the needs of the member countries in terms of supporting them during this COVID-19 pandemic. And then the fourth thing the bank went into, because if you look at everything I've said, we are an organization that thrive on leveraging investment and bringing it into the healthcare space. We are also an organization that thrives on partnership. So we partnered with the AU, the AU CDC, UNECA, and the AU Special Envoy, Steve Masiyiwa, to develop the African Medical Supplies Platform. Because one of the things we discovered was, okay, when you lend money to these governments to purchase these COVID-19 materials that are needed, where do they go to get this? If you recall, at the beginning of this pandemic, there was a lot of constraint on the supply chain, especially for African countries. So the African Medical Platform was created to ensure that African countries have a platform they can access to purchase medical equipment such as diagnostic kits, PPE, clinical medical devices, and at cost, with increased cost effectiveness and transparency, of course. And so for us as an institution, I would state again, we believe that the solution to improving the healthcare sector in Africa lies in getting all critical players, governments, donors, FIs, DFIs, investors, to work together in leveraging private investments and integrating it effectively into the healthcare sector. We will continue to work together with all our partners, and we are available to support private businesses on the continent to cope with the impact of this COVID-19 pandemic, and more importantly, even beyond the COVID-19 pandemic, to sort of develop the African healthcare system we want, with financial solutions and even non-financial solutions. We are even open to advocacy where necessary to support the development of healthcare in Africa. Thank you.
Thank you very much, Oluranti. A lot of information there. We move quickly to a partner spotlight before we go to the questions.
I'm Samba Bachilu, CEO and founder of ADS Group, Africa Development Solution, also co-founder of Equally. Equally, that's mean equal access to quality healthcare. The main services provided by Equally is a health checkup from the bottom line, the last line. Because if you want to achieve universal health coverage, you need to do that approach. There's no other solution. I'm sorry to say, we are doing sick care because the problem, we only try to solve when people are sick. Healthcare should be done before, so we need to prevent.
AWS is the world's most comprehensive and broadly adopted cloud platform. Millions of customers trust AWS to power their infrastructure and applications. Organizations of every type and size are using AWS to lower costs, become more agile, and innovate faster. AWS provides on-demand delivery of technology services via the internet with pay-as-you-go pricing. You can use these services to build and run virtually any type of application without upfront costs or ongoing commitments. You only pay for what you use. AWS gives you more services and more features within those services than any other cloud provider. This makes it faster, easier, and more cost-effective to move your existing applications to the cloud and to build anything you can imagine. From infrastructure technologies like compute, storage, and databases, to emerging technologies such as machine learning and artificial intelligence, data lakes and analytics, and Internet of Things. Building on AWS means you can choose the right tool for the job. For example, AWS offers the widest variety of databases that are purpose-built for different types of applications. With AWS, you can leverage the latest technologies to experiment and innovate more quickly. We are continually accelerating our pace of innovation to invent entirely new technologies you can use to transform your business. Like pioneering the serverless computing space with the launch of AWS Lambda, which lets developers run their code without provisioning or managing servers. And AWS built Amazon SageMaker, a fully managed machine learning service that empowers everyday developers and scientists to use machine learning without any previous experience. We are constantly expanding our global network of AWS regions, so you can access AWS services to build and run your applications from anywhere in the world. Each of these regions has multiple availability zones that are physically separated from each other and connected by low latency, high throughput, and highly redundant networking. This makes it easy to design and operate applications that are scalable, fault tolerant, and highly available. Our infrastructure is built to satisfy the security standards of the most risk-sensitive organizations. You also have access to the AWS Partner Network, which has thousands of systems integrators who specialize in AWS services, and tens of thousands of independent software vendors who adapt their technology to work on AWS. With the largest community of customers across every industry, AWS has unmatched experience and operational expertise you can depend upon for your most important applications in every imaginable use case.
Thank you. Thank you very, very much. I think that we have half an hour now to get into the gist with the panelists on what you presented and what you didn't present, and interact with the many participants who've been sending lots and lots of questions. To the participants, I apologize upfront that we may not be able to mention you by name or put across all your individual questions. What we've done, however, is to try and summarize some of the more common thematic areas from which the questions are addressing. The first one, Justine, you are with UNFPA, focusing on reproductive health. For many years, focusing on primary health care. Over the last couple of years, our countries have been focusing on UHC. And one wants to believe that UHC, with a three-legged approach, access, quality, and the removal of the punishing effect of the cost of care. One would imagine that that UHC approach would embrace reproductive health, maternal health. It would embrace preventive care. And that if it had embracing preventive care, it would also embrace the preventive aspects of COVID, which is the only thing that we have against COVID right now. It is prevention, it is not cure. To what extent would you say that the programs as you know them can be expanded to embrace the fight against COVID rather than starting afresh as if we never had primary care, we never had prevention, and we never had all those community outreaches? Justine.
No, thanks very much. I mean, I think that work is already happening, and I work specifically in East and Southern Africa, so I'm going to talk specifically about that region. But you know, as much as you know, there are still weaknesses in the Africa healthcare system, and I've worked in this particular region for about 12 years. I have seen, even over that time, some substantive improvements, both in terms of, we can see that in the numbers, in terms of improvements in reductions in maternal death, but I think also in terms of the quality of professionals we're seeing coming through national health systems as well. I mean, that there are good things happening there. And so actually many governments reached out to us immediately to say, look, we know that we need to focus on continuity of services. We know there are going to be challenges, particularly, let's take, for example, pregnant women. And so how can we work with you to ensure that services are continued? And we've had a number of things going on. So I think, you know, going back to Philippe's comment on telemedicine or using mobile technology, you know, one of the first things was we took all of the COVID-19 prevention treatment curricula, particularly for midwives, and put that into a virtual format. So midwives can access that online or over their phone, etc. We also converted helplines that may previously have been for survivors of GBV or those who had questions about sexual reproductive health, and actually open those helplines up to healthcare workers, recognizing that many of them did not get the information fast enough that they needed. They were hearing all of these stories in the news around COVID-19. They were scared, understandably, and our primary focus working in partnership with governments was keeping health workers in health facilities, providing services safely, both for them and for the patient. We did a lot of work around supply chains, ensuring that, PPE and other needed commodities could be bought quickly and put through supply chains into health facilities, particularly those providing reproductive healthcare services. So a lot was done. One of the things we did see very early on was the way that lockdowns were done, because obviously very often that's not about the Ministry of Health, that's sometimes around the police on the street who are actually making sure those lockdowns are taking place. They were very often done in an extremely heavy-handed way, and it was because information wasn't passed equally across Ministry of Health and then other ministries, such as those dealing with the police. The other thing we saw as well was, certain retail outlets or others that overinterpreted messages. So for example, we saw in one retail outlet, and actually a chain outlet in South Africa, that condoms were cut off for sale, were prevented from being sold as an interpretation of not being able to sell non-essential products. So in many ways, our work has been very much tailored to specific contexts and working very quickly with our partners on the ground to ensure that the disruption to services is minimized. Thanks.
Thank you. There's lots of questions coming on the private sector. On one side, there are people who are questioning whether there are good private sector models that can serve Africa, both the poor and the rich, sustainably. On the other hand, there's questions about the cost of financing to the private sector and whether the current global economic framework would allow private sector to be funded in a manner that they can sustain services for the poor. On the other side, there's questions about the embracing of technology that the private sector says it has and could help Africa. Give us a sense in these three areas on where you see the private sector making a major breakthrough that would also serve our current problems with COVID.
So I'm going to...
I'll give that to Philippe.
Oh, okay.
Yes. Philip, are you with me? You're muted.
I'm with you. Now I'm not muted, so I'm with you, but fine. So, yes, sometimes we tend to oppose private sector and public sector. And effectively, in many countries, you see that, and it's a pity. And it was the case, for example, in India some years ago, that you have a private sector working for the rich without economies of scale, with high prices, and public sector working for the poor. I think that now, if I look at a country like India, where we have a lot of experience, it's over. I mean, the government has asked to the private sector to contribute to giving care to the poor. Starting, they were reluctant because they were saying, why? I mean, we are paid less, but at the end, first of all, they contribute to the nation, but secondly, it creates economies of scales. If you have huge, if you just work for a few rich, you don't have economies of scale. If you contribute to a massive program that covers the 70% of the population that are below poverty in India, effectively, you can also create economies of scale. And also, it can contribute to give care when you don't have public infrastructure, and it can contribute also to challenge public infrastructure. What we saw in India is that the public sector improved its quality because also it was challenged for the private sector. Obviously, it was challenged by the good private sector. So I think we have permanently to, obviously, you have to have some element of regulation. Always the state has to finance, always the state has to put the rules, but within this, market can bring efficiency, like in infrastructure. I mean, you can perfectly have a public good regulated by the state, but both on the market and leverage, and it can attract international investors, etc. Africa did this or is doing this for airport, for stadium, so why not for health? So I think there is a good partnership to create between public sector and private sector, and you have not to oppose both. Yes.
Made it clear there that really it's not a binary choice between public and private. We have to find a way of getting these things together.
Exactly.
There's something that I want to put on the table. Thanks to COVID, that our leaders and people who have money in Africa now can't fly out, and we can treat their common cold in the continent, thanks to COVID. But then when I look at your slides and the list of institutions that you have funded, it's juxtaposed to the questions that are coming from a lot of participants. As I said before, the backbone private sector and the reach to the majority of Africans is through the small provider, that nurse midwife who's retired and is opening a clinic in my village, and so on. I don't see those people in your loaning framework. The small man, the small girl. Two, recently we have seen that because of COVID, the health sector is suffering. Private clinics are not seeing patients anymore because people are keeping away. And yet, I've not heard of a specific, sector-specific economic stimulus to this sector. Give us a sense that there can be hope, and give us a way forward on how we address money to the people who treat most of our population, and we save them from collapse because of COVID. Ms. Oluranti.
Thank you, Prof, for this very, very apt question. If you recall, when I was presenting, I'd mentioned a 200 million facility that the bank had put in place in support under a UNECA, Afreximbank UNECA initiative. What we've done is that through this facility, we know that we cannot on our own directly, reach out and on-lend to those small businesses you are talking about. The small businesses that impact people's lives every day, those small businesses involved in medical and health sector, the small labs, the equipment manufacturing, So what we've done is that we've partnered with trade finance intermediaries and specific SME finance intermediaries. We have tried to identify intermediaries, financial institutions across the continent who generally have been supporting these businesses. And maybe because of the COVID pandemic, might not be able to continue supporting them. So what we've done is to try and engage them and to create a special financing from them so that these financial institutions can continue to support these SMEs even through this pandemic. So that is one thing we've done, different from what we would have normally done before. So we are talking to our trade finance intermediaries and specifically talking to them to identify small and medium scale enterprises involved in the healthcare sector whom they had been financing before, but for one reason or the other, because of the pandemic, they are struggling to finance, and we are providing loans, guarantees, just to facilitate this financing to ensure it doesn't stop. And we are doing this at special pricing because we understand also, we do not want a situation where the cost passed to these SMEs also is unbearable because they are struggling right now. Then for the private clinics that are not seeing patients anymore, depending on the scale of the clinics, we are able to directly support some because, like I mentioned to you, the PATIMFA, which is a pandemic mitigation facility, is not just to countries. It's also corporate organizations are also able to benefit from it. And these are organizations that have been affected because of the impact of the pandemic. Their businesses have been affected. They cannot make trade payments. They cannot meet their regular business needs. So we have also created a facility that can directly support organizations who we can on-lend to directly. For those we cannot on-lend to directly because they are small, they are SMEs, we have also specifically gone ahead to identify specific trade finance intermediaries who generally are willing to take on this risk to continue lending to these SMEs on the back of Afreximbank's support.
Thank you very much for that response. Justine, I want you to tackle this one briefly, but specifically because it will also be your last remark because of time. COVID is a different kind of a challenge, but Africa must see it as an opportunity. And I'm trying to get from you, being an advisor for many governments in the region, the kind of conversation that you'd have with government leadership that would, number one, make them see COVID as an opportunity, and whether you'd be willing that that opportunity should be used to completely reorganize the financing mechanism and strategies. The reason why I'm saying that is that unlike other epidemics that have started in Africa, this one started outside Africa. And some of the countries that we usually go to for assistance are also under the weather. And some of the agencies that we always go to for technical support are also unable to even treat themselves in their own countries. I'm not mentioning CDC in America. So what would you advise that we do differently?
Thanks. I actually want to preface my comment by questioning something you said earlier about the progress we've made on UHC. Because what we've seen as UNFPA is trying to move forward on UHC in a way that can bring the private sector in to work in partnership with public sector rather than two separate options that are offered to service users, I think has been extremely challenging. And I think one of the reasons for that is the ability for the two sectors to have dialogue with common interest is a challenge, yes, because very often the public sector feels, why should I give any of my scarce resources to you as the private sector, because I don't have enough anyway. And the private sector may look at the public sector and go, but you're so slow and inefficient, how can we ever work with you? And I think one of the things, you know, we need to deliver on UHC. We have to find a new way of delivering universal health coverage, which definitely includes the private sector as a core partner in that. And I think one of the opportunities that is presented to us by COVID-19 is in a number of countries, the private sector has been extremely quick to go to governments and offer assistance. They've been able to show their particular skills around logistics, around strengthening supply chains, around being able to very quickly provide additional care facilities, for example, in a way that would take the government much slower to do. And so I think that's where the opportunity is, because I think there is a certain element of goodwill that currently exists between public sector, private sector, and that gives us this opportunity to look at that UHC conversation again and ideally come to the table with this, without this sense of distrust. And I say that actually not just from an advisor, because many years ago I used to work for a non-governmental health organization that was trying to work contracted into a PPP model, and that was extremely challenging. And so we've got to make PP models to deliver UHC to work, I think, for both sectors equally, and we're not at that point. So that's where the conversation is. And that's actually what we're trying to broker, are these different dialogues around how we can bring in private sector expertise to work with public sector to really deliver on UHC and sustainable financing in different ways.
Thank you very much, Justine. Philippe, in your wrap-up remarks, I want you to address one thing. Questions are coming, and you've also mentioned it, about innovation and the use of technologies. You rightfully highlighted the success of the money movement of M-Pesa in Kenya. And being Kenyan, I cannot imagine how people are managing countries where they don't have M-Pesa in this time of COVID, when nobody wants to go and queue in a bank. So give me 2 or 3 low-hanging technological opportunities that Africa could grab and that could enable us to overcome COVID. 1, 2, or none? Philippe?
Okay, yes. I think that Justine already mentioned that, for example, during COVID, we saw a takeoff of telemedicine because people were not wanting to go to the doctor, because obviously the medical centers were centers of contagion. And I think that, yes, telemedicine is a way to limit the contagion of epidemics, but it's also a way to implement universal health in an efficient manner. So definitely telemedicine, and it can be linked to mobile phone, is effectively one of our technology that will help to tackle COVID, but will help definitively in the development of health system. I think that also, probably, perhaps the vaccine will come from emerging countries. We know that Indians that have developed a lot the drug industry, but also Brazilians, perhaps will discover the vaccine. It will not come for the first time from more mature countries. And for sure, the development of drug manufacturing, or at least more efficient way to import drugs, is a levies for African universal health. That are my 2 ideas. In general, I think, yes, the emerging countries now are leading the way, and fast developing countries, China, India, but soon Africa, are leading the way in IT now. And probably the next medical technologies, the next medical systems will come from these countries. If I look, for example, some Indian states have developed systems to manage in a cashless manner all their universal health for 2 billion euro. For 2 billion euro, in Europe, you develop nothing. So it means that these continents are now more efficient, and I'm sure next systems will come from also from Africa. So it's not all linked to COVID, but definitely technology is a levis.
Very hopeful, Philippe, and that's a good place for you to end. But I'm going to Ms. Oluranti. Ms. Oluranti, all the time we tell Africa that it must change, it must do things differently. But we don't tell our partners that they must also change and do something interesting. You heading and are related to a very, very important financial institution for us. What are some of the critical changes, minimum, that you'd think we should ask of financial institutions that are working with Africa in this sector in the era of COVID-19? You're the only one who can answer that question.
Thank you, Prof. I think for us, what we've done or what we are trying to push out there is that we want all our partners on the continent to see African healthcare as a viable business, not just an aid or a donor business that must be tied to, providing support to governments. We want to attract more investment into the healthcare space. We want to use this to improve technologies within the healthcare sector. We want to use this to improve resourcing within the healthcare sector. We want to use this to, ensure that what the current trend we are seeing, which is, before the COVID-19 pandemic struck, which you also mentioned, was, a large outbound of medical tourism from the continent. But now no one can travel, so everyone must stay on the continent. So we want to use this to see our partner FIs, DFIs, invest more in African healthcare from a business perspective. Thank you.
Thank you very much, Oluranti. Our time is up, and I am being pressurized to get off the stage. And I do so gracefully, with great thank you to all of you as I hand over to Jacob.
Thank you, Professor Kamu, for taking us through the session, and all the speakers who've taken part through the session. Thank you. Having come to the end of the first webinar series, on behalf of Africa Health Business, I wish to extend a special thank you to all our event partners who made this event possible. We further extend our gratitude to all the moderators and keynote speakers who took us through the 5 sessions. In response to the COVID-19 pandemic, Africa Health Business has established the Africa Response to COVID-19 platform, ARC. The ARC platform will serve as a hub to coordinate knowledge, communication, and need assessment as they relate to private sector response to COVID-19. It will initially focus on 4 priority thematic areas, which are telehealth and mHealth, testing, tracking, and treating, human resource for health, and financing models for healthcare. If you are interested in engaging with the ARC platform, please reach out to us through the contacts provided. Finally, it is our pleasure to welcome you to partner with us in curating the upcoming second AHBS webinar series from the 29th of October to the 26th of November. In this second series, we envision the ignition of conversations leading to partnerships for stronger, resilient health systems. Partnerships that will without a doubt alleviate the financial, manufacturing, infrastructural, and disease burden on the healthcare system around the African continent. For more details on how you can partner with us on this project, contact Mr. Nishit Shah, our Partnerships Director at AHB. As we leave, please watch a short clip from AHB. Thank you for your time and do have a lovely weekend.
Thank you.